Hey, welcome back. Thanks for checking in again. Now, this is part 6 of the video series for ICD9. Alright, so now we're actually going to get into the meat and potatoes of things here. So far, you have a general overview of how the book is structured, how to find a code. So now what we're going to do is how to actually go through the individual chapters. Excuse me. Right now this video is only for chapters 1 through 4, but once we're done you should be able to have, once you know chapters 1 through 4, you're pretty good. Alright, so let's get going. Alright, so the big item in chapter 1, obviously chapter 1 is the infectious disease and parasitic organisms. So one of the first items that you have to know about is on HIV. Alright, so the most important item is you cannot code HIV unless it has been confirmed. Confirmation can be in the form of the actual diagnostic statement saying the person is HIV positive, or is a HIV patient, or a patient with HIV related illnesses. Right? It's very important that you do not code an individual with this code unless the person has been confirmed. If the individual indeed has been confirmed, then the code that we give this individual is 042. Right, so 042 is a confirmed HIV code. Once you code the 042, you can also code any symptoms or any HIV related illnesses afterwards. So let's say for instance the person had HIV and as a result developed pneumonia, or let's say developed Kaposi sarcoma. Then you code the pneumonia and the Kaposi sarcoma after you already code the 042. Right. Now, if a HIV patient is admitted for something that is unrelated to their HIV, then you don't have to code. Actually, I shouldn't say you don't have to. You should not code the HIV first. You should code whatever reason the person is here, and then afterwards you can code the HIV and any other HIV related sick illnesses afterwards. So again, if you have a patient with a prior diagnosis of HIV related illness, you can code this individual 042. Right? If the individual is coming in for just testing, trying to determine the HIV status, then you're going to give this person a V code. Right? The V code in this case is V73.89. Once the individual comes back for counseling, you can give that person the V6544. Alright. So when the person returns, so let's say for instance the person comes in for the status and the person returns, this is the code the individual is going to get. Now there is another code that you can also tack onto the individual code for the determinant status, or even an HIV for the HIV status. This is a V69.8. All this code is saying is that the person has behaviors that put that individual at a higher risk for developing HIV. Alright. Now, if the person is not HIV positive, if the person does not have the related symptoms when the person comes in, this person is categorized as having a being asymptomatic, meaning without symptoms. So when a person is without symptoms, what we do is to give this individual V08 code, a V code. Alright, so whenever there is no documentation or no diagnostic statement stating this person is HIV positive, but there might be documentation saying something to the effect of possible HIV individual. This person has been listed as HIV positive in the past, or HIV test positive in the past, but there is no actual test in the record, anything of that nature. Or this might even be some sort of secondary data that you hold in. Well, in this case, this person gets a V08. Right? Now, let's say, for instance, the person gets the V08, but then the person now exhibits some HIV-related sicknesses. Then this person can now get a 042 code. Now, the inconclusive HIV serology 795.71, this code is used for an individual whose test results come back inconclusive. All right, simple as that. And that code comes from a sign and symptoms section of the, which is chapter 16 of the ICD9 volume 1. Now, earlier on, I said that if you had an individual who had AIDS and then the person developed, let's say, some other HIV-related sicknesses, what you would do is you would sequence the HIV first. As with most things in coding, there are usually exceptions. There are two exceptions in the book. Right? First exception is any code that comes from chapter 11 of volume 1. Right? Chapter 11 deals with complications of pregnancy. And any code that comes from chapter 15, which deals with the baby, those codes always take precedence. It means that those codes always comes first, no matter what. So, as I mentioned earlier, even if the person had HIV and it was coming for HIV related treatment, you would still have to code something from the something from the chapter 11, or if it was dealing with chapter 15 code first. So those codes always take priority, 11 and 15. And because 11 and 15, 11 belongs to the mother and 15 belongs to the baby, you never have to worry about which one should you put first, since both take priority, because those are two different individuals. Okay. Actually, I think I was recording this without the speaker in there, so the other voice may not be as loud, which is pretty silly. Anyway, I'm just tired, that's all. Alright, so encounters for testing for HIV. Alright, this is pretty much a review of what we just went through. If the person is coming for status screening, it's V7389. If the person indeed does have some sort of risk factors that make this individual more likely to have HIV, then you also have to put that as well. Right. Now, so that's all there is to know for HIV. Right. For cases dealing with systemic inflammatory response syndromes, right, septicemia, sepsis, severe sepsis, the number one item that you need to know is that you are likely going to be dealing with two codes, because you're essentially dealing with blood, in the layman's term, blood poisoning. All right. Which means you have to account for the infection itself, and then you have to account for whatever caused the infection. All right. So let's say, for instance, you have septicemia, right, which is just a systemic disease that's associated with some sort of pathological microorganism. Right. So essentially, you have toxins in your blood, right, poison blood. SIRS, or systemic response infection. Alright, systemic inflammatory response syndrome. Right, this is just a systemic response to that particular infection. So if you have that infection, and let's say the infection could be, it doesn't have to always be infection. It could be from trauma. It doesn't have to originate from some microorganism. It could be from trauma, or burn, or cancer even. Right. Sepsis, and sepsis, excuse me, is the systemic inflammatory response that is due to an infection, right? Though there, and also severe sepsis, which will obviously be the advanced stage of sepsis, but specifically with acute organ dysfunction, and that's a very important item to remember. There must be an organ dysfunction, right? If there is an organ dysfunction, then you may have to look at a separate code. All right, so again, coding any of the above codes is going to require at least two minimum codes, right? Because you're going to be looking at the infection, and then you're looking at the excuse me, the outcome. All right, so you always code the underlying cause as well. In which case, the code from 9959 category is going to be what we use. All right, remember that systemic inflammatory response can never be principal. It can never be a primary code, because just listen to the word. It's response syndrome. It's response to something else. It's response to an infection, right? Therefore, it cannot be first. That means you have to have the infection code first, right? So when it comes to systemic inflammatory response syndrome, you have to code the underlying cause. The underlying cause can be an infection or it can be trauma, but just keep in mind it can never come first. So first you have to code is the underlying disease. Once you code the underlying cause, then you can code the systemic inflammatory response. All right. Now, when you have sepsis and severe sepsis, line is 038.9, which is essentially unspecified code, specifically on unspecified septicemia. All right, now let's talk about a little bit about this, because it's the same thing. You just, as I said before, all right. Severe sepsis is acute dysfunction of the organ. So if there is no organ dysfunction, all right, then you're not going to be able to use the code for it. All right. If you have an acute dysfunction and it's not related to sepsis, for one, you don't have to. Well, I shouldn't say you don't have to. You should not be coding 995.92. All right. So if somebody came to the hospital, the person is admitted, and the person had a let's say a kidney fail, you don't automatically just go ahead and code sepsis just because the kidney failed, right? Severe sepsis is a requirement. Organ dysfunction is a requirement for severe sepsis, but it's not the other way around. Just because the person has organ dysfunction doesn't mean you automatically go ahead and code sepsis, which I think for the most part most people understand that concept. All right. So let's say we have bacterial sepsis and septicemia. Right. If the document states that it's just, let's say something like streptococcal sepsis, then what you do is you just simply sign 038, and then you sign streptococcal septicemia, which is a 995 code. Right. I hope that makes sense. Again, if the document states we have a streptococcus sepsis, you first assign the 038 code, all right, for septicemia, and then you assign the 995.91 in this case, right, for the sepsis. All right, so the 038 is for the actual septicemia, 995 is for the severe sepsis, or excuse me, for the sepsis. And if there was a severe sepsis, then you also assign that as well. If the document only states streptococcal septicemia, that means we don't have sepsis. We only have septicemia. Alright? But if it says streptococcal sepsis, basically what this means is that the document doesn't have to say the patient has streptococcal septicemia sepsis. It just would be silly to say that. So as long as it says streptococcal sepsis, you already assume that there is septicemia because one, and then you also code streptococcal sepsis as well. Okay. Septic shock is just circulatory failure due to the severe sepsis. So here you're gonna have to code the systemic infection, and then you're gonna code 995. But specifically for this case, though, you're also going to be coding 785.52 for the circulatory failure. Right. If you have septic shock, but there's no documentation of severe, and I should say severe, obviously, but there's no documentation of severe sepsis, then in this case you just code the 995 code and then the 785. Right. So the septic shock and then the sepsis, or excuse me, the severe sepsis. Negative or inconclusive blood cultures, just you have to do some investigation to find out, because you don't want to just sit there and not code anything. Alright, let's say we have sepsis due to procedural infection. So this is just a complication code, specifically 998.59, which is just post-procedural infection, which you can simply find by going under complication and then looking for post-procedure. Alright. And this is just going back to what we talked about already. I'll just move forward. Alright, so severe sepsis associated with non-infectious process. Again, it is possible to have sepsis or severe sepsis that may not be directly related to an infection. If this be the case, then you're gonna have to code whatever the cause is. It can either be a burn or some sort of injury. Alright, and early on we talked about, from the other part, we mentioned septicemia, and then in part, I believe it was part 4, I was talking about combination codes, and I was explaining why what combinations codes are. So for instance, we have 041.12, which is MRSA, methicillin resistant Staphylococcus aureus, right? There is no need to code MRSA and then code anything else, because the code that you're getting already contains everything, right? It contains the organism and it contains the disease, right? So you don't have to go and code anything else. That's just something to keep mindful of. Now, chapter 2 is probably one of my favorite sections because it's a very simple item. You have cancer and then you have not cancer. Alright, simple as that. Well, actually, it's not that simple. But as far as looking for your code, it's a pretty simple process. Alright, there are 3 possible choices for malignant or cancerous process. It's primary, secondary, carcinoma in situ. Primary is the original location or the original site. Secondary is wherever the cancer may have metastasized to. Carcinoma in situ is cancer that is still still located in the original spot. Essentially has not spread. Right? If it's benign, then it's not cancerous. If it says that it's uncertain behavior, right, that means that as of this point, it is inconclusive as to whether the tumor or the growth is cancerous or not cancerous. And if it's unspecified, that means you do not have enough documentation to make the determination. Right? To find a cancer of any place, all you simply have to do, let's say you're looking for cancer of the liver, right? You simply just go to the Neoplasm chart, you locate liver, and then you go across to figure out whether it's primary, secondary, carcinoma in situ. It's really just that simple. Right? Now, there are some items that you have to be careful about, some things you have to be aware of when you deal with cancer. In terms of sequencing, right? Let's say the person comes in to be treated for the cancer. You obviously will designate the cancer as the principal. Alright. So if the person is coming in for treatment of the primary cancer, you would designate the primary cancer. Alright. Unless the person was coming in for let's say something like chemotherapy, then you put chemotherapy first and then the cancer itself. Right? If the person is coming in for treatment for the secondary site, right, you only have to code the secondary site, even though the primary site may still exist. Right? When you deal with an individual who has cancer and anemia, code the anemia and then the cancer if the person is there for anemia treatment. When you have a person with anemia and anemia is associated with chemotherapy or radiation, or and the treatment is directed specifically at anemia, you do the same thing. You're going to code the anemia first, and then here you're going to actually code an E code, E933.1, and then you code whatever the actual cancer itself is. So this is for a case where anemia is associated with chemotherapy treatment. Right? So the chemo or the radiation caused anemia, right? And the person is here for treatment for the anemia. You code in the anemia first, you code in the E code, and then you code in the appropriate neoplasm, whichever. Alright, so I hope that makes sense to you. Alright, essentially what's happening here is the chemotherapy or the radiation is affecting the individual's blood, in this case causing anemia. Alright, so if the person is here to be treated for the anemia, you don't code the cancer first. You're just going to code the anemia and then code the E code. Right? And also you're going to code the excuse me, the actual neoplasm. Alright, so let's say other complications of neoplasm. So we already just talked about the process you follow if you deal with chemotherapy. Let's say if you have kind of similar situation. In this case, it's not anemia, but it's something like dehydration due to chemotherapy. You're going to code the dehydration first. Right? If the patient is admitted for chemo and develops the complication, and then you're going to code the chemo first. Right? So in the first scenario, the person is receiving treatment for dehydration due to chemo. We code the chemo first. Code the dehydration first. The admission for the dehydration. In the second scenario, the patient is admitted for chemotherapy. Alright? Not for dehydration. The person is admitted for chemotherapy and then develops complication. In this case, you code the chemotherapy first. If you have a treatment of complication resulting from some other surgical procedures, then you code the complications first. So in all the scenarios, we essentially coding the complications. In this case, this complication was dehydration, so that came first. In the second scenario, the complication was actually chemo. Right? It was from chemo, so we code the chemo first. Use of the V code for history. Alright, V10 is for a history of neoplasm, specifically personal neoplasm. So you can only use this if the neoplasm itself is no longer existent. Right, so if the neoplasm, if the cancer is still there, you don't code as a history of. You just code it as primary. If the person has an encounter for the removal, obviously you code the neoplasm first, and then if the person is receiving chemo, you also do the chemo code, which is V58.11. Now here's another weird thing too, and I guess it's not weird. Let's say someone donates. Let's say you receive a kidney as a donation. Let's say a year passed, 2 years passed, 3 years, 5 years or something passed. That donated kidney now becomes cancerous. Well, here you're gonna have to follow a few steps. The first step you're gonna follow is you're gonna be coding the complication code. The 996 code is a complication code, and it's essentially a complication of cancer, or specifically complication of a donated organ that's formed a cancer. And then you're going to be coding a cancer code stating that the donated organ is cancerous, and then you code the actual cancer itself. Alright. So let's say, again, let's use the kidney as the example. An individual comes in, and the issue is that the person has a donated kidney. Right? The kidney that was donated to the individual has now become cancerous. You cannot just go ahead and code, just go to the neoplasm and simply come up with a kidney code. Right? Because this is a special scenario. This is a scenario in which the individual's cancer did not develop from his own body. So it's a complication. So what you have to do first is you have to code let's say, complication of a transplanted organ. So that's what 996.8 is. And in case if it was a kidney, it would be 996.81. That's specifically for a kidney. All right. Now, once you code the complication code, the 996.81 in our scenario for the kidney, we now need to code 199.2. What 199.2 is saying is that we have a malignant neoplasm that is associated with a transplanted organ. So it's almost like it's saying this twice, really. And then after that, we can go into the neoplasm chart and find our kidney code. All right, so here we'll be coming up with three separate codes to describe this scenario. Now, if a primary neoplasm has been removed, if it has been eradicated, then you can code it as a V10 code or V10 point, whichever specific code it is. If a patient comes in and is encountered for admission for chemo, again, you code the chemotherapy first if this is a treatment, ongoing treatment. But if it's the first time, then obviously you're going to code the neoplasm first. And here's the neoplasm chart, which we mentioned several times already. All right. So just like the chart says it, all right. If a person was here for an abdominal cancer, we just have to determine first of all we already have abdominal, and then these are the separate codes that specify this different parts of it, different types of growth or different neoplasms. In our case, if it was primary, then it would be 195.2. However, if you were looking, if the documentation didn't state, then it would be 239.89. Right? Again, for M codes, you don't have to worry about Appendix A codes. Right? The M codes are designated and are assigned by the tumor register. And I believe this is the last section that we're going to cover is diabetes. Right? Diabetes is chapter 3 of your volume 1. Now, diabetes can be difficult in the beginning for a lot of students, but it's really simple. The way the diabetes is labeled when you go to look for it in the index, right, it's labeled as etiology and manifestation. That means that if the person has diabetes with something, right, it will always be labeled as diabetes code first, and then in brackets it will give you the manifestation. Now, a few things to know about diabetes. Whenever it is not given to you as to whether diabetes is type 1 or type 2, we always default it to type 2. Type 1 diabetics always use insulin. However, if the documentation says the person is insulin user, don't automatically assume that it's only type 1, because type 2 can also use insulin as well. Whenever it comes to diabetes, right, there will always be 5 digits. There are no exceptions. Right? So if you're writing down 4 digits for diabetes, you already know it's wrong. It always has to be 5 digits. There are absolutely no exception. Right? If you have diabetes with something, you always code the diabetes first. You code the manifestation second. Right? Now, there are 2 categories of diabetes in the book. Category 250 and category 249. 249 is secondary. Now, do not confuse the word secondary diabetes here with type 2 diabetes. Right? People always get that confused. Right? Secondary diabetes simply means it was caused by something else. Right? And for instance, it could be caused by some sort of kidney failure, or it could be caused by cystic fibrosis, something like that. All right? So it's caused by something else. All right? Now, again, this is the structure of the ICD9 structure for diabetes. It always begins with 250, unless we're talking about secondary, then it begins with 249. As we already mentioned before, 250 will be category. If you had a 4th digit, it would be subcategory, and if you have a 5th digit, it would be subclassification. In diabetes, however, the 4th digit and the 5th digit also have special meaning. Right? The 4th digit is still the subcategory, but the fourth digit stands for, or it represents, the manifestation code. So whatever the outcome of the diabetes is. So if the person had diabetes with neurological manifestation, then the fourth digit here would be represent neurological manifestation. And the fifth digit will categorize the type of diabetes, whether it's type 1 or type 2. And here's a list of the manifestation codes. You don't have to memorize these. Eventually, after you work with them, you get to know them. So if a person had no manifestation, if the person had diabetes but there was no manifestation, no outcome, no complication, then it would just be 0.0. Right? If the person has neurological manifestation, then it would be 0.6. So the code would be 250.6, and then you tack on the fifth digit, which would be the type of diabetes. Right? Now, as far as the fifth digit goes, right, there are 4 possible choices, and they range from 0 to 3. 0 will be for an individual. Let's go back. 0 will be for an individual who has type 2 diabetes, and the documentation does not state that it's uncontrolled. Right? As you can see, 0 and 2 are both for type 2. The difference here is that 2 says uncontrolled, whereas 0 says not state as uncontrolled. Same thing goes for 1 and 3. 1 and 3 both are used for type 1 diabetics, right? Juvenile diabetics. 1 does not state that it's uncontrolled, whereas 3 specifically state that it is uncontrolled. And that's how that works. Alright, so if you had a person who had diabetes mellitus with neurological manifestation, it would be 250.6. Now, if you were to say that it was a type 1 diabetes, then we have to tack on 1 for not state as uncontrolled. Okay. And then you, of course, also code the actual neurological manifestation, whichever it happens to be. Okay. If a patient is routinely receiving insulin, you can also attach V58.67 code as well. If you have an individual who comes in and has an insulin pump failure, and the person either underdose or overdose, then these are some codes you can attach to it. So 996.57. And then if it's overdose, you also attack on 962.3 as well. Right? And this is the last chapter we're going to cover for this video. Right? Blood diseases. Alright. Specifically, anemia is the biggest one in this chapter. Anemia is the most common blood disorder. Right. So again, going back to what we talked about, if you had anemia and the person also had cancer, what you do is you add this code 285.22, which is anemia in neoplastic disease. Alright. And that's really all the big thing that you have to know. If you have anemia in chronic disease, that is not the same as anemia chronic disease. Right? The word "in" is very specific here. Right? Anemia chronic disease is not the same as anemia in chronic disease. Right? So keep eye on those. And I believe that is the last of the shows here. Alright, see you in part 7. Okay.